Our next panel is about hard-won lessons from the front lines of clinical AI. We have our lovely moderator, Angela Aristidou, who is a faculty fellow of the Digital Economy Lab of the Stanford Human-Centered AI Institute, and also an assistant professor of the University College of London. And on this panel, we have Dr. Toyin Falola, who is the Associate Vice President, Clinical Strategy and Product Development at Providence Health. Side note, she mentored me through residency because she was also a dermatology resident at Stanford. Dr. Chen, Head of Clinical AI at Ambience Healthcare. Dr. Sneha Jain, Clinical Assistant Professor, Department of Medicine and Division of Cardiovascular Medicine here at Stanford. And Dr. Joseph Izzo, who's the Chief Medical Information Officer at San Joaquin General Hospital. So an excellent mix of people from all kinds of institutions and backgrounds. I'm so excited, and I will hand it off to Dr. Aristidou for moderating.
As we heard earlier from Julia, she brought us right into the middle of the conversation about delivery science. And what we are going to learn more about today is how to go into the front lines and learn the hard lessons that these four experts here have to share with us today about how to bring AI into the real world, in the hands of clinicians, in real world clinical settings. And I am absolutely delighted to be moderating this session because that's what a lot of my research is about. I actually try to understand how to make it work and how to make it work more effectively for as many different settings as possible that we can have. That's another luxury we have today. We have people from different backgrounds who are engaging with the same puzzle from different perspectives. And that's why I'm going to ask you each to take a minute to introduce yourselves and the unique perspective you bring, and then also share with us one, I'm going to be strict with this one, just one lesson that you would like to share or a challenge that you would like to share with us regarding AI implementation. Let's start from here.
Awesome. I'll kick us off. Super excited to be here. I'm Ray. I am clinically a hospitalist, but also the head of clinical AI at Ambience Healthcare. And I guess the lesson or insight that I would share is I think how often we still fundamentally misunderstand the shape of the problem within AI applications in healthcare. I think very early in my journey or even back to my training, I saw many mismatches between highly technical solutions and clinical problems that were either non-existent or trivial in nature. And I was always hopeful that over time, as the field advanced, that we get better matches and be able to better understand the problems that we're trying to solve. And I think tying it to our work at Ambience, early on, I think we had to still recognize that writing clinical notes is not just a transcription problem or a summarization problem, but really that we needed to make sure that it was coding aware to think about the downstream implications of compliance and billing, and also to think about specialties, just like we have separate trainings of residency and fellowship. We had to take our models through residency and fellowship to understand the nuances of every single specialty we're going to serve. So I think really understanding and tying it back to first principles of understanding the problem that we're trying to solve has really helped us a lot, and I think been a valuable insight in how we build.
Absolutely. And what I will also touch upon is that you mentioned hopeful. I think of myself as a pragmatic optimist when it comes to AI and health. And I'm going to keep that as well from what you just said. Jain?
Hi, also a pleasure to be here. And Roxana was my favorite mentee at Stanford. So
you say that about everyone.
I do say about everyone. So board certified dermatologist by training. I lead clinical innovation and product strategy at Providence, which is a large integrated healthcare system that crosses 7 states, mostly on the West Coast. So my lesson is a very short parable that I use a lot at work. I don't know if you guys know this one. It's the chicken and the pig. So a chicken and a pig are taking a walk, and they say, oh, we should open a restaurant. And the pig says, the chicken says, how about ham and eggs? And the pig says, no, I would just be committed and you would just be involved. And I think about that parable a lot, actually, because a lot of these technologies ultimately affect clinicians, right? And often we don't involve them at all in the development of the technologies. And I tell my team a lot, we are the pigs. Everything we have rides on this, right? And so I think the biggest lesson I've learned is to think about the end user, which we're talking about health AI, clinicians and patients, at the very beginning of the ideation and the product development cycle, because often those questions that they bring up about how it will impact their workflows and their joy of work are the things that you should be thinking about throughout the entire product development cycle. So that's just my lesson for
That's
today.
so meaningful. And that also touches upon the first question that Julia presented us with today about starting with the patient and then engaging the pipeline backwards. Thank you so much.
Hey everyone, I'm excited to be here as well. I'm Joseph Izzo. I'm an emergency physician and a chief medical information officer for San Joaquin General Hospital. It's a level 2 trauma center and public teaching hospital in Central Valley, California. I want to say that my lessons are very similar, that we have very motivated but smaller teams that are able to roll out a number of tools, and very motivated physicians who, for the first time in my experience, actually want to engage in technology and get excited with this wave. But a lot of vendors come to the table not necessarily prepared to work with a system such as ours, whether that's the practice environment of a county hospital, whether that's the differing resources at a county hospital, or maybe even the regulations that we're more subject to as a county facility. And so I agree that dialogue needs to start from the beginning, because more than ever before, we have so many physicians who want to be part of this discussion. And if you engage with them early on, you'll have a good rollout.
Amazing. Hi, I'm Sneha Jain. I'm a cardiologist here at Stanford and a clinical assistant professor of medicine. I spend a portion of my time working with the data science team within the hospital to develop, evaluate, and deploy AI tools across the enterprise. And I think my lesson, because I can only pick one, is just how much everything besides the technology matters for successful AI deployment. We spend so much time thinking about the cool new thing, the technology, and how amazing it is. And we have many scientists very invested in developing these new set of tools. But in our deployments, the tool has been maybe like 5% of the work. And I'll give you a concrete example. We just went live 2 weeks ago with a tool that identifies patients at risk for peripheral artery disease. And who here knows what peripheral artery disease is? Okay, wow, that's better than I expected, actually, because in general, 70% of the US does not know what it is, but it's basically blocked arteries to the legs associated with increased risk of heart attack, stroke, any sort of blocked arteries elsewhere in the body. And these patients are at risk for amputation, at risk for bad morbidity and mortality. But anyway, we developed this tool and deployed it within Stanford, but getting the tool right took weeks. Getting the workflow right took months, and it took incredible teams of providers who were really invested. Shout out to Dr. Andrew Shetman and Dr. Ari Fukaya from Primary Care and Vascular Medicine. It took a lot of iteration on workflow, and that whole process and the change management process is really where most of the work was.
Okay, that gives me a pretty good leeway for the next question, which is most of AI initiatives, pilots or projects never make it past the pilot stage. So tell us, what made a difference in your specific organization? Let's start with Sneha, since you started that conversation.
Sure. I think for us, it's a process called the Responsible AI Lifecycle. This is our governance process. And this is a process that was put together by our chief data scientist, Nigam Shah, as well as our chief information officer, Dr. Mike Pfeffer. And I think many systems are developing governance structures, but I think there are 3 key components that has made it successful here. One is who is involved in the ultimate go, no-go decision-making for whether AI tools get deployed. And at our institution, this group is called the Data Science Executive Committee, and it is co-chaired by Topher Sharp, our Chief Medical Information Officer, and David Entwistle, the CEO and President of Stanford Healthcare. Now, these are busy people. They've got a lot of stuff they have to work on, right? But they're co-chairing this committee. Why? And I think it has to do with this idea that AI, while some AI tools are incremental in the advancements that they're causing, some are transformational. They're disruptive in terms of how we practice medicine and how we deliver healthcare. And unless you have the buy-in and the oversight of the highest levels of leadership, those kinds of innovations don't tend to flourish. And this goes back to innovation theory, Clay Christensen's work from Harvard Business School, where if you have truly disruptive innovation that changes how you operate a business or operate a healthcare system, it will not survive if it's somewhere buried in the context of a healthcare organization, because everybody there is understandably trying to optimize for doing the process that currently exists better, not necessarily rethinking the process. So you need a direct line to the CEO, to the leadership, to help sponsor, support, and protect some of these innovations that might be truly disruptive.
So, Joseph, do you have a direct line to the CEO?
Yes, absolutely.
Okay, tell us about it.
And I think it's
Are
so
there any
easy.
CEOs in the room I need to know about? No? Okay, we can talk freely. Go ahead.
Sure, yeah. And I'm sure he's not listening. So I'm no stranger to the perpetual pilot. It's much easier, but that's not the right way to go about this. And about a year ago, when we were presented with a clinician demand, particularly for ambient AI, but a number of other tools, got everyone in the room together, CEO included, and really started demoing the tools and got a chance to see what everyone's biggest fears were. I think the first time you see one of them in action, you start to think of things like the Terminator or other kind of end of world scenarios. And it's nice to have everyone right there at the table, able to sort of weigh in on their fears and also be able to contribute to the governance decisions, like you mentioned. So I drafted a policy and circulated around this group. It included representatives from the county. We had a sort of a process for how we're going to vet each tool, and then how to adhere to that policy that we created. So everyone had that knowledge in advance, because problems will happen, right? There's going to be hiccups. There's going to be situations that arise. Maybe there's a regulatory concern. Maybe there's a patient safety. And being able to handle that in advance allows you to prepare. The other thing that's really important for us is having really strong clinical leaders. I work really closely with the chair of emergency medicine, internal medicine, vascular, urology. These are all physicians who are very focused on technology. Some of them have backgrounds in engineering, and they are perfect pilot physicians. They can guide me and my team on what workflows need improvement, and also be almost like evangelists to their department, so that when they are using the tools and they understand the limitations, that there will be hiccups, as they progress to the point where we're ready to roll out, they can permeate that momentum throughout their department. The only other thing I want to mention is it's also important to have that line with the vendors. I tend to select vendors that are willing to work with us in our system and be responsive to change.
Toyin, actually, he said system, and you're leading AI change across systems, so this is perfect.
Yeah, that was a great tee up. So I'm at Providence Health. We're huge, right? We're across 7 states. We have 1,000 clinics, 51 hospitals, 127,000 employees. Of those, 44,000 are nurses, 45,000 are doctors. So we are a big, big system. So I hear the word pilot all the time. But I think something really has changed, and I think it's a confluence of 2 things. One really is, I would say, the transformational, I love that word, impact of AI. And I think something happened in our system where, our CEO got to go and meet with executives at OpenAI, and he came back and was like, this is transformational, right? And so I think when people see it and see and AI, of course, is not a product in and of itself, but a tool that enables products. But when you see a product enabled by AI, it really just changes the person who's seen it in a way that I think in a few years ago, that wouldn't have had the same impact at the highest levels of healthcare organizations, at the same time where we are hitting a huge impact in terms of our workforce, right? We are at historic levels of burnout, historic levels of patient access issues, and revitalizing the practice of medicine is now really an existential crisis that health systems have. When people I mean that like colloquially say, AI is going to replace doctors, I laugh. Which doctors? Where are these doctors that you found? We don't have them, right? And so I just think that it's really a time of both transformational technology at a time where it's an existential need for it to maintain the joy of the practice of medicine for our clinicians, as well as to enable patient access at a time when it's so low and so dire, that this is the time for the technologies. And I think that has enabled things to move out of pilot phase much quicker than historically would have happened.
I put that together with what we heard earlier from Julia about different other forms of technology that came into the health space earlier, were sometimes motivated by external crises like COVID-19 or regulatory shifts like electronic patient records. And what you added to that is that as we're moving into the AI space, it's an existential crisis from within. I love that. Thank you.
So I think I'll just add to continue on the themes of partnership here is that, really finding the right partner and helping collaborate, pair with them, understand each other's motivations has been an incredibly powerful tool. Like a lot of us here, I think coming from a background in academia, I used to be skeptical of industry as well and some of their motivations. But then actually, diving into this world, what we really want to do often is actually to build products at scale to have that impact and mission. Right? We actually sit in a room together and say, what are the problems we want to solve? For example, I think sitting with recently some of the clinical leaders at Cleveland Clinic, I see some here today actually, essentially to align and understand that we actually have the same problems, we want to solve the same problems, and partnering closely on that roadmap and vision can really increase that product clock speed and allow us to build, iterate, and move beyond pilots quickly and to deliver that real world impact. Because that's where, that's why we actually all came to work in this field. That's why we believe in the transformative nature of AI, as you guys have said, but we want to build those products at scale and continue to iterate quickly.
So you move beyond the pilot impact and you move beyond the point of the pilot. And I guess that's your question next, Sneha. How do you actually evaluate the clinical quality care, patient outcomes out of an AI implementation when it's moved beyond the AI pilot stage?
Absolutely. I think, and this actually gets to a question that Ron Lee just asked Julia at this last at the keynote speech, which is, do you evaluate the tool, the workflow, both, and in what situations? And I think part of it, you need to evaluate all of it, I think. And the level of rigor, I think, is dependent on how risky the process is and how much risk there is to patients or to providers. But I think it's really important to think about what metrics matter. Let me give you an example of a standard traditional AI tool that maybe flags people at risk for some rare disease. If you have that rare disease and you find all these people, but you don't have very many specialists to see them, you've overwhelmed your capacity. We heard about this as well in Julia's talk. Now, there could be maybe a series of AI tools, maybe an LLM agent that serves as a way to democratize that specialist care. There's some great work going on in that space. But you have to think about, in this case, the specificity. How many false positives are you feeding through the system that might overwhelm the system? For generative AI tools, you want to make sure that you're evaluating on the real task at hand. I don't really care how well the LLM performs on USMLE, but I do care about when it's deployed in a specific healthcare context, the job to be done in that context. And I guess to just round that out, I think so much of this depends on doing evaluation to build trust in the healthcare system. And I'll give you one example. This is an implementation that I was involved with at another institution for cardiac amyloid. This is misfolded proteins that enter into the heart muscle and cause heart failure. The tool was incredible. And when we deployed it, for the people who we were able to get under the scanner, we diagnosed a significantly increased number of people. It went from diagnosing 12% of people to half of the people we scanned. And that matters because there's drugs that halt instead of reverse the disease. But we were only able to get, for every 5 people that we identified as high risk, we were only able to get 1 to 2 people under the scanner. Why? Because providers either declined or didn't respond. And so it's really important that we build trust, we think about the workflows that we develop, and time permits later, we'll talk about how we've done it differently for others.
Beautiful, beautiful. And then also I want to hear from Joseph in terms of being in a public teaching hospital. How does that work for you?
Yeah, and I will say, I'll get the easy one out of the way. We're very resource limited and constrained, so we are very budget conscious when we make tool decisions. To make a pilot go successfully into a rollout, I need to monitor in real time and make sure it's making both either objective or subjective differences and be willing to part with a tool that isn't working for us. From a regulatory standpoint, a county facility is transparent and also answers, in addition to the federal and state level, to the county level. And you may be aware that there's, particularly in California, a number of assembly and state bills that affect our practice of AI and try to regulate. And they may be competing with other mandates, but they also may be outpacing the tool's ability to regulate themselves. And working with a vendor that's able to adapt to that is key. For the county level, they have understandable caution, and we make many efforts, like we mentioned with governance, to actually work with the county administrators, work with county council, make sure our policies align with the county level IT. And that's helped us to get a sense before we do any kind of investigation to the tool to know where it's safe to go, where we're comfortable going. I want to shift gears too, because you mentioned public teaching hospital, and Julia made this point too, is we are only now just comfortable rolling out some of our tools to our senior residents. And at a teaching hospital, all of the tools that reduce administrative burden tend to potentially also take away from the educational value of repeating those tasks over and over again. And I don't have an answer, just like Julia had mentioned. I don't know where to go with this. But what we are doing is, I think the best defense is sort of awareness. Our programs are incorporating AI into their grand rounds, into their morning reports. We're about to do one as a facility for all of the incoming residents in August. And I hope that gives our residents an understanding of what is on the horizon, what it will be like when they enter the workforce. And we'll carefully pilot these with our residents. The only other thing I want to mention is, if that's okay, is for our patients. You had mentioned it, and Julie had mentioned it too, that all these tools may not be trained on our patient population. And so we have to be very cautious with predictors. We found that a lot of them don't work for our patients, and so I find vendors that are willing to work on that level.
That's so important, and that goes beyond just knowing which data set the tool was trained on. It's actually, how does it work in context? That's such a great point. Toyin, you've worked on AI strategy at scale, so the question to you is slightly different. What do you wish that health leaders would be aware of, or learn better or understand better about working with AI vendors?
So, like you, I also don't think of vendors as a bad word, mostly because I came from startups before I worked at Providence. I've been on the other side, and for me personally, I find that particularly with how fast the technology is moving, a lot of the advancements come from industry. Startups are really the engines of innovation in this country. I believe that very strongly, and they're at the forefront of utilizing this technology and developing it so quickly that sometimes I see pitches from startups and I'm like, what? Where did this come from? I had no idea this was happening. And so I think that when you want to be at the front lines of really understanding innovation, partnering closely with industry colleagues, whether that's big technology companies or entrepreneurial startups, really is how you know what's happening in the field. And I think whoever mentioned on the panel, I think Ray did, especially if you want to have a lesson about working with industry or vendors, is that you want to have a close partnership. I've been really buoyed by the ability to work with our industry colleagues and our entrepreneurial startup colleagues and really think about, how do we design IRB proposals? How do we design the pilot? We have a very robust evaluation process internally for AI tools, and I've also been really appreciative of companies enabling us to get some of the source data so we can run our own evaluations and understand if we trust the data that we're getting. And so a lot of that close partnership and working with partners who are also transparent, because they know that you're in this together, that you're developing this technology together for the benefit of our patients and for the benefit of our communities, often are the ways in which you're able to have a lot more success. And so I think thinking about it like a partnership and finding people who will be transparent so that your institution can feel comfortable implementing these technologies is often what I've seen lead to success.
Fantastic. And the flip side to that question comes to you, which is, what do you wish AI vendors understood better about working with health system leaders?
Yeah, absolutely. I think it's a lot, continuing to echo on the themes, I think, of partnership. Going back to almost the Cleveland Clinic example, being able to have that buy-in and collaboration to solve these really hard problems is actually what moves us both forward. Right? You guys spoke about metrics. You spoke about some of the challenges in terms of thinking about trainees, residents, fellows. But there's actually also ways to use the AI tools to help augment that. And think about potentially, for example, graders for notes. Just like we can use them for our automated notes, we could use them for essentially trainee use as well. But it is, again, that buy-in and partnership that allows us to do potentially really hard tasks that we actually couldn't have done alone. For example, Cleveland Clinic, we rolled it out to about 4,000 clinicians and onboarded them and trained them in about 6 weeks, I think, which is something we never could have done on our own or with any other health system without having that buy-in first and having that partnership to build together. And then as we think about how we approach the next frontier of difficult challenges that we're going to solve, whether that's pre-charting, whether that's thinking about expanding the pipeline to supporting triage intake, and and some of the advanced capabilities of clinical reasoning. We have to be able to understand these problems and have that kind of buy-in and partnership from them to really, again, accelerate, roll out safely, and then understand the metrics that we want to measure together to ensure that they're performing well and continue to be monitored safely as they continue to be rolled out.
The theme of partnership is very strong here, and I echo that. I really do think that this is going to be the era of the partnership. What I want to hear is the added voice to that conversation, which is, how do you, Sneha and Joseph, feel about what would you like the AI vendors and the health system leaders to be aware of in terms of your clinical realities, where these tools will find themselves a home?
Sure. You can probably imagine in my clinical environment that things can be fast-paced, high stakes, and the closer these tools get to patient care, the more cautious we have to be. So the few things that I've noticed are, number one, physicians don't have time to troubleshoot. They don't have time to maybe work on 50 notes and then have a promise of a reduced burden. Same idea as if they have to go outside of their workflows or what they're comfortable with, they don't wish, it's much harder to get buy-in when that's the case. And maybe even just when it comes to some of our overcaution with regulation, just knowing, like I mentioned, that a vendor is willing to work with us on that. But to the original point I had made, a lot of physicians are willing to come to this conversation. So I agree, partnership has what's been successful for our vendors.
Yeah, I think trying to do something outside of a clinician's normal workflow is almost a no-go. The other part of it is, like, it's not just good enough to give great information. Like, there are so many tools out there that'll be like, I'm going to tell you about all of these risks that your patient has so you can act on them. That's not helpful, right? And I think the best vendors and best AI tools are ones that say, we have this really cool technology and we have a way to make it really easy to act on it, where it's almost, you really need minimal effort on the part of the physician or the provider who's already doing so many other things.
That makes a lot of sense in so many contexts, and even more so in the context of health. When you are thinking about keeping tools long-term in your settings, how closely do you think about future-proofing them? So what steps do you take to make sure that they speak to each other, that they work well with each other, that they work together in order to support the health outputs or the health clinical outputs in the setting?
This is such a great question. I think there's some things that you can do up front, but a lot has to do with monitoring tools over time and making adjustments as you go about. Because really, you might not know what the future holds and what you need to future-proof against, but if you have a process of monitoring where on a monthly or quarterly basis, you have the ability to turn on, turn off tools, whether they work to fix them if they're not working or make them fit better in a system, that process of a real focus on monitoring, I think, is what allows you to future-proof.
Joseph?
Yeah, 100%. And I'll just add that having our executive team and our governance folks stay informed. Folks who typically were not involved with technology initiatives are now going to conferences specifically at the intersection of their fields, for example, risk management and AI, so that they understand what's around the horizon. The other, and I agree 100% with monitoring, we have a deep learning algorithm for stroke diagnostics. If we're not looking at all those cases to make sure they're making a difference, are they helping or hurting? That's the key to it. So.
A lot of those CEOs come to executive programs that are taught by myself and other colleagues in management and business schools. And most of the time, what they come with is problems and a vague understanding that this technology might help solve the problems. And the rest of it is up for grabs, essentially. So what I did hear you talk about before was the role of the AI champion, the idea that there is this person or people within the organization who will champion the technology and translate it across different functions, different specialties, and within the organization serve that role. Is that something that you see in a more structured way, or is it something that grows organically in your settings?
I'll make a comment to the earlier one and then this one. And one is just a thank you to all the academicians who are pushing this field forward. A lot of some of the frameworks that we're using internally at a large integrated community-based health system were developed at Stanford or were done in collaboration with folks at CHI. And so, I think in academia, you don't always know the impact of the work that you're doing on everyday people. And so we obviously in the community are very thankful for the work being done, especially here at Stanford. And then to answer your question, I think the AI champion is critical. And I think now, especially to the trainees, we need a new type of clinician. The ones who are training now who understand both clinical medicine, informatics, artificial intelligence, and other emerging technologies are the ones who are at the forefront of being the AI champions because they actually understand both all the hard stuff about medicine, but also about the technology. And that's not, how everyone is trained. People here are lucky to be in the Bay Area and get that sort of advanced training where your training is actually replicating what's happening in real world industry. But I think that sort of eye on how do we think about who the new type of clinician will be, and because those are the ones who will be these champions that are developing actually, and implementing these technologies is going to have to spread beyond where we are now to, frankly, internationally.
I think that's a great vision to have. And yes, indeed, that's the person we want to see leading in the front lines of this change. How about you? What would that person engage with in terms of your role as an AI vendor? How would you engage with those AI champions or with that form of system that's slightly different than what we consider traditionally as the norm?
Yeah, absolutely. So I think AI champions have been critical, again, in building that relationship and once again helping us to understand these hard problems that we're trying to solve. So for example, AI champions at some of our health systems have been able to bring in that clinician that almost is so technology resistant or still on their flip phones, and the ones that said we would never try something like this.
We don't know any of those.
They may not be in this room. They may not be in this room, but I think you all know the person that's likes to handwrite everything and then is at the in clinic at the end of the day still working on their notes because one, they have a deep dedication to their patients, but two, that they're struggling. And then to have those AI champions be able to reach out to them, connect with them, and as a colleague, as a friend, to be able to convince them to try these things. And ultimately, these are some of the actually strongest and most heaviest users that we end up getting is people who are traditionally more technology averse. And so to unlock that in terms of helping essentially utilization and kind of expand and grow the technology and these tools. And the other flavor AI champion is very useful is kind of being able to help us develop, being the one that's able to understand the technology and its limitations, being able to help us innovate and give us feedback quickly on how do we iterate and build the next version even better. And so those almost the alpha user type. So I think those two frameworks of essentially AI champions are very helpful as we build and grow from a pilot.
Thank you, Ray. That was a nice roundup. And now I'm going to take questions for our panel. And please, don't be shy. We really do want to hear what you took from this conversation and where you would like us to take this conversation towards. I see a hand back there. Can you introduce yourself before you ask your question?
VP of Discovery Research at Veracyte, which is an oncology diagnostic company. And Sneha, I had a question specifically for you in terms of making it easy for the physician, right? Does that look like clinical evidence and coming with the clinical evidence so that you can actually act on what these tools are telling you, or something else?
I think the clinical evidence is, in my mind, kind of the bare minimum. The other parts of it is when an AI tool is integrated into workflow, making it easy to act upon. And the example I'll give is for our PAD diagnosis algorithm. So patients who are identified as high risk, instead of just showing that to the physician saying, hey, this patient's high risk, maybe you should evaluate, we've built a whole system around it where the patient automatically gets sent a question asking about symptoms of leg pain. And if the patient doesn't answer the question, well, that's okay. There's a backup where the MA is going to ask that question before they even get to the provider. And then the provider has a really easy one-click system to send the referral to vascular medicine for further evaluation. But let's say they run out of time, they can't click on it. That's okay, we have a backup. This is an opt-out or thing where if they say, we don't want you to contact our patient for XYZ reason, we won't. But then if not, we will reach out from vascular clinic and we have a champion within primary care who will send these patients and more like a population health method. So I think what I'm trying to share is that the workflow has processes in place to make it as easy for everyone in the system and backups for those processes to make it easy.
Hello, my name is Paz Dozinama. I'm actually an incoming M2 from Meharry Medical College. And I really took hold to the last point you guys talked about on the new clinician. And I wondered, what advice would you give for students that are kind of starting their medical career and seeing that AI is becoming more prominent in the healthcare system? What advice you would have for students? Thank you.
Good on you coming to this conference. That's the best advice.
It's a good first step.
It's a great first step. Just medicine is changing so rapidly that I really feel strongly about this new type of clinician. And so I think, first off, there's amazing ways to get information. New England Journal of Medicine now has an AI, there's just evidence-based journals now that have AI-specific publications around them. So that's first and foremost one. I think societies are getting really good about integrating AI curriculum into their annual conferences or their meetings or curriculum. I think the information now is so democratized that I frankly follow different people on LinkedIn and subscribe to all these Substacks. There's just really great ways to get information out there now. And there's several AI sort of leaders in the field that I follow that are in this room. I think Daniel from Kaiser and Ron Lee from Stanford that publish and speak about it a lot. And I tend to follow, I was fangirling, I tend to follow them and get lessons from them as well. And I think just from an educational standpoint, obviously there are, board certifications you can have in clinical informatics as well, which I think kind of can bolster your education into understanding data and analytics. And then lastly, you can never learn more than building and developing these tools. And so being able to figure out how you can, within your institution, be that clinical champion. Hey, I want to be part of the pilots. I want to be the person who thinks about the technology. I want to help build and develop them. I just don't think there's any better learning than working with the tools up close and up personal. But I'm sure you guys.
Yeah, and there's even tools, say your organization is restrictive. There's open source EMRs. There's ways to plug in some of the large language models to get familiar with that. That's something I've done with my my residents and students as well, to avoid that risk of approaching patient care or any kind of organizational regulation.
I'll also just add, I think, similar to those themes, is also just stay curious. I mean, you clearly have an interest in this. I think what the path for me ended up being, a postdoc in informatics and then starting like an AI ML lab. But I think different people have arrived in this field in different ways. And being curious and figuring out which best suits your interests. Some of our strongest actual, technical folks actually started off as just people who learned it by themselves and learned coding on their own. And so having that drive, that curiosity to figure out what interests you the most and then really chasing that down and again, taking the initiatives to, for example, come to events like this is, I think, a core piece to unlocking all of it.
Hi, I'm Joseph J. Williams. I'm an assistant professor in computer science and psychology. So I've been working on using prompt engineering where people can experiment with the prompt that they give to a chatbot like clinicians, because when you choose a prompt or instructions, you define an interactive app. So I'm curious, have you all seen people who are doing interesting work where they teach clinicians how to do this kind of prompt engineering, like varying sentence by sentence, especially using small experiments? Or what do you think are interesting or impactful directions to teach people how to do this?
We're actually doing that internally at Providence, just because I think the more people have an understanding of AI, the better they are to both develop and then implement these products. So we had an immersion course that we developed internally, actually in partnership with a large technology company. And so we were able to have people learn about different prompts, test prompts. We had a way that you could they provided us an ability to even allow us to put in PHI and PII so they could test it with patients. And so I think things like that, and the feedback has been wonderful. And so we're going to try to do it again in the fall. So I love the idea, and I would encourage other institutions to try to do something similar.
I'm Dr. Wesley Allen Williams. I'm a postdoc here at Stanford with the Live-In Lab and Song Lab. So it's PET imaging AI and also using a molecular docking software for peptide theranostics for prostate cancer, metastatic castration-resistant prostate cancer. So I have kind of a hardball question. Have you? For the end. Yeah. So I'm curious if you guys have done any research on possible conflicts of interest with AI implementation in hospital systems. So earlier it was said that there's like a lot of kind of lack of positions and a lot of burnout, which would be awesome to alleviate burnout. But is it possible that this implementation, if it kind of accelerates, would it kind of prevent job openings or kind of induce job loss within certain levels within the hospital system at all? Or have you seen any research?
So you're asking about unintentional...
Yeah, unintentional side effects. Yeah.
Not conflicts of interest in the medical sense.
Yeah, okay.
I think I can answer that. When we started rolling out our ambient tool for the ED, we also had human scribes, and we thought that they would go away, like there would be no need for them. But all they've done, and this is a theme I keep hearing throughout these conversations, is just adapt to a new role within that framework. So these scribes now are talking more to the patient, following up on results, getting more information, reviewing the note, pulling in radiology, and doing things that they probably wouldn't have had the time to do as scribes. But what's interesting is that actually makes them closer to medicine, which is why they typically go into the field.
I think that's so well said. And then the other thing that we will do is an ethics evaluation before deployment to try to think about the unintended consequences and try to create mitigation strategies around that. And this work is led by Michelle Mello, Danton Char, if you want to take a look at some more of that.
She's at the back of the room.
Oh, there she is. She's waving.
I will say that the testimonials that we receive from our clinical teams after implementing various AI technologies, whether that's ambient, documentation or clinical decision support, is actually what keeps me doing the job that I'm doing. A lot of them have said that it literally is revitalizing their practice of medicine. And I'll leave you with a story where a busy clinician called our office and said, I talked to a patient about gardening today. And I was like, why are you calling innovation about this? And they said, I have not been able to talk to a patient about their personal life in years. And by using both clinical decision support and ambient dictation technology, which is more than just dictation, of course, they were able to get back to restoring the joy of medicine and what we call, we're a faith-based organization, the sacred encounter of the practice of medicine. And that's actually what keeps me motivated. I think it is really the ability to allow our clinicians to get the joy of practice.
I'm told we're running out of time. Ray, last comment, quickly.
Yeah. I'll just say that just similar story in that as we know, healthcare is so resource strapped and we have an aging population facing increasing demands that anything that we can do to help alleviate some of those burdens not only brings the joy back in medicine, but can also have additional benefits. For example, democratizing care or giving access to specialists in rural areas that previously did not have those. I think that's the transformative nature of healthcare as a tool, bringing additional benefits. And certainly we should think critically about additional unintended consequences, but so far, because we're kind of bandwidth strapped right now, we've just been able to free up to do additional things that traditionally are core to why we wanted to jump in and practice medicine to begin with.
Fantastic. So I want a round of applause because they have shared with us quite a lot in a very, very meaningful way. Thank you. Thank you so much. And thanks for all the great questions.